All right, guys. Good morning. So for those people online, I'm Julie Brown. I'm a ER EMS physician at UAB. Today we are going to go through some cases, try to be a little more fun, a little bit more interactive. There are no wrong answers. And if you're worried that your answer is wrong, the people online probably can't hear the people in the room, so it's okay. So we're going to go through some cases, and then talk about treatment and how to resuscitate them. Okay. All right, so kind of to start with, there was this position statement put out by the National EMS Advisory Council in 2009 that asked the big question, does EMS make a difference? They also asked, do pre-hospital interventions really improve patient outcomes? Does what you're doing outside of the hospital matter? And can timely care provided in the pre-hospital setting lead to reduced total healthcare expenditures? And what do y'all think the answer was? Yes. Yeah, for sure. So this came out after about 50 years of research and evidence proving that yes, EMS makes a difference. And I think that's awesome, right? Like what you're doing in the pre-hospital setting matters. What you're doing to help patients matters. So in that statement, they said that kind of initial scoop and run approach that relied primarily on transporting patients and not actually providing a lot of care wasn't the best way to do it, right? And so as EMS systems have improved, so has training and education of EMS providers. And they found that there have been positive outcomes. So patients that have done well in the pre-hospital setting from treatment for specific conditions, primarily STEMIs, respiratory distress, stroke, trauma, sudden cardiac death, and then patients in pediatric shock. But a common element in all of these is that integration of EMS into a coordinated system of pre-hospital care. So we know what we're doing, the hospital knows what we're doing. We're trying to get the patients the best care. All right, so we're gonna start with the case. So we have a 54-year-old male that has chest pain. So he's on his way to work, pulled over, called 911. He said it really felt like a burning pain. That took some Tums, it didn't help. He's like, I haven't been to a doctor in, since I was a teenager, probably within 40 years. But he does take sildenafil, which y'all know what that is? Yeah, so he's taking it for ED, so it's Viagra. It's the other name for it. He gets that prescribed online, but has no drug allergies. I'd say he's pretty soft, borderline hypotensive, a little bradycardic, satting okay on room air. His D6 98, which is fine. But you look at him, he is profusely sweating. He's holding his chest, the positive Levine sign, holding his chest. But his lungs sound great. So what do y'all want to do? Yeah. Yeah, this is his 12 lead. What do y'all want to do now? Yeah, so we want to get him to the hospital, right? So y'all can see it's a STEMI. So he's got elevations 2, 3 AVF, and then some depressions in 1 AVL, probably V2, V3, probably V4. So that's a STEMI, right? And the biggest thing you can do in the pre-hospital setting is being able to recognize a STEMI. Because if you take this patient to like a freestanding ER, there's not a lot that they can do for them, right? So why do we care about STEMIs? So in the US, someone experiences a heart attack every 26 seconds. So for the time I've been talking, like 6 people have had a heart attack. That's wild. And about 1 person dies each minute from ACS or acute coronary syndrome. And about half of those patients who are having an acute MI use EMS. And a lot of other patients that aren't having an MI call EMS for chest pain, right? Like how many patients do you see in a day that have chest pain? In the Birmingham area, it's probably the majority, right? So in that position statement, that 2009 paper that came out, they found that coordinated systems of out-of-hospital care improve patient outcomes in treating cardiovascular disease. But what is actually improving that survival and what is actually improving outcomes? So they found that it was getting an EKG and interpreting it, notifying a receiving hospital and activating the cath lab, triaging directly to a PCI center, so patients or hospitals that can do stents, and then administering thrombolytics. So this is not a lecture specifically on ACS, but what is a STEMI? So the far right side of the screen, a STEMI is characterized by complete occlusion of a blood vessel. So you have your coronary arteries in your heart, and you have complete occlusion of blood flow. And so you get injury or infarct. And that's represented on EKG by ST elevations. And then if they're in a hospital setting, an elevated troponin. And so if you get an EKG, in order to read it, the leads correlate typically with the coronary arteries. So I usually go inferior leads first. So 2, 3, and AVF or the inferior leads are usually the RCA, right coronary artery. Sometimes they can be the circumflex, but usually the right coronary. The lateral leads, 1, AVL, V5, V6, are typically the circumflex artery. And then the anterior septal leads, V1 through V4, are typically the LAD. And so you can figure out where the patient's having an infarct, right? This is just another picture, I think, that is kind of pretty. It shows the aorta, where the coronaries are coming off in the heart, and it makes it easier for you to remember RCA versus circumflex versus LAD. And if you just like Google like coronary arteries STEMI, you'll see these pictures. All right, so this guy, this is our patient, the 54-year-old. Where's his infarct? What do y'all see? Inferior, yeah. So he's having 2, 3, and AVF are hit where his ST elevations are. So that's an inferior MI. So correlating usually to the right coronary. All right, so what are we going to do to resuscitate him? So in the pre-hospital setting, the best thing we can do is get them to the right hospital at the right time, right? Because time to reperfusion is the biggest way for us to determine a patient's morbidity and mortality. And for patients that are treated with PCI or treated with like a stent or balloon, each 30 minutes of delay increases their relative risk of 1-year mortality by 7.5%, which is huge. So we want to make sure that we're getting an EKG, recognizing the STEMI, because sometimes that machine is not going to read STEMI, and it's a STEMI, right? I have an EKG at the very end of the slideshow that is a very clear STEMI that the computer was like, femoral sinus, and that's bad, right? We want to make sure we can recognize it. All right, so we already kind of talked about this, but what do we want to do to treat this guy? So we talked about aspirin, talked about putting a nasal cannula on him. Really, he doesn't need oxygen right now based on AHA guidelines, but I would say put a nasal cannula on him so that you're ready to crank that up whenever he decompensates on you, right? He's bradycardic, he's hypotensive, he's going to get sicker, right? I'd put the pads on him for whenever he does crump on you. It's going to happen. Just assume it's going to happen. I would not give nitro, which we'll talk about in the next couple slides. And then what is the next best thing you need to do? Call the hospital. Let them know you're coming.
IV fluid.
IV fluids, yeah, especially in this guy, right? He's hypotensive,
Yep.
having inferior MI. That's just that. All right, so why do we not want to give nitro? So nitro acts because it's a smooth muscle, causes smooth muscle relaxation, and it's a vasodilator. So it typically vasodilates veins more than arteries, but it does both. And when you dilate your veins, you decrease that preload, so that you're decreasing the amount of blood getting back to the heart, so the heart doesn't have to pump as hard. And so you can increase your coronary perfusion and decrease your cardiac oxygen demand. And it can dilate the coronary arteries to improve collateral blood flow. But why do we not want to give it in this guy? So a right ventricular infarct can complicate about 40% of inferior STEMIs from an RCA. And these patients are very preload dependent because if you have an RV infarct, so that right ventricle is infarcting, that right ventricle is not pumping, right? So that right ventricle is not pumping, it really needs that preload in order to get that blood to the left side of the heart to perfuse the body and the coronaries, right? And so if you get an EKG, things that could be suggestive of an RV infarct would be ST elevation of V1, depression in V2, or elevation in 3 greater than 2. You're not necessarily always going to see all these things, but you can assume it if they're having an inferior MI, just and they're borderline hypotensive or hypotensive, assume it probably involving the RV. And in this EKG, I'd say greater elevation in 3 greater than 2, and he's got some elevation in V1. This is not the same patient though. And then this man is also on sildenafil or Viagra, and that's a contraindication to give nitro, especially if they've taken it in the last, I'd say probably, 48 hours, because that medicine is also a smooth muscle relaxer and a vasodilator. And so if you're vasodilating all your veins and arteries, you're gonna have no preload. And this guy is already very preload dependent, right? All right, so now he's getting altered and confused. What do we want to do now? Another set of vitals, perfect. Now he's hypotensive for real, and he's even more bradycardic. Why do y'all think that's happened?
Decompensating.
Yeah. So say we gave him some fluids that didn't really help. He's still downtrending. Fluids didn't help. So you get another EKG. It's maybe a little hard to see, but do y'all see anything wonky here? I mean, definitely has the STEMI still. But look at the bottom leads. Yeah.
Dropping a P wave and your DR interval is increasing, so it looks like a.
Yeah, so with inferior STEMIs, this is in the next slide, you can get blocks. This is actually a 3rd degree, but it can be kind of confusing. So you see P wave, probably a P wave, probably a P wave here. So your P waves are marching out and your QRSs are marching out. So this is actually a 3rd degree block. So that's probably why this guy's even more hypotensive now, more bradycardic. So why do these patients with inferior STEMIs or RCA infarcts get blocks? It happens in about 20% of patients, and it's because the RCA, the right coronary, supplies the AV nodal artery. And so if you're infarcting that or occluding that RCA, you're not getting blood flow to the AV nodal artery, and so you're not supplying the AV node. So then the AV node gets ischemic. They also can have increased vagal tone due to the ischemia. Most of the times this is transient, so it only lasts hours to days, but in the time that you have the patient, they're going to be sick, right? Typically it responds pretty well to atropine and usually doesn't require permanent pacing, so it doesn't need a permanent pacemaker, but a lot of times these patients do need temporary pacing, so pacing in the pre-hospital setting or in the ER. So you give this man atropine, 1 milligram every 3 to 5 minutes. Say he doesn't get better, so then we need to pace him. How are we going to pace him? What do you do to pace somebody? Yeah, so put the pads on him. We're going to set a rate. We're going to start going up on the milliamps until we get electrical capture, but then we want to make sure we also have mechanical capture. So you can get electrical capture on the monitor. We want to make sure that's translating to a pulse, right? All right, so any questions on that case? I was a sick inferior STEMI. But see why I say, like, go ahead and put the nasal cannula on them, go ahead and put the pads on them, because these patients are usually going to crump on you. And if they don't, oh, great, awesome. But expect the worst in a STEMI. All right, case 2. You have a 2-year-old, has rash and difficulty breathing. Just so you know, she's about 15 kilos. She ate some cookies that her neighbor brought her. Full term, no medical problems, doesn't take any meds, no allergies, vaccines are up to date, but she's hypotensive. I'd say probably tachycardic, a little tachypneic, and her stats aren't great. She's only statting 85% on Rumare. She looks in pretty bad distress. She's audibly wheezing, and she has diffuse hives. What do y'all think's going on?
Allergic reaction.
Yeah, but what type of allergic reaction? What is this? What protocol are you going to use? Anaphylaxis. Yeah, so this is anaphylaxis. And that's the key point I want to make here. I feel like a lot of times in the ER and in the pre-hospital setting, we say allergic reaction and we treat it like an allergic reaction, like with just Benadryl, but this person needs epi.
Yeah.
Right? They need epi. And that's the distinction I want to make with this case. 1 milligram IM? No. Yeah. Yeah. And that's later in the slide, but yeah. So what is anaphylaxis? So anaphylaxis is an acute, life-threatening systemic hypersensitivity reaction caused by the sudden release of mast cells. And that's a lot of words to say it happens fast and patients get sick, and it's because mast cells degranulate or release all their contents. It's usually IgE mediated, which is just the antibody that's causing this, usually due to food, drugs, insect stings, but really any agent that is capable of degranulating or making mast cells release their contents can induce anaphylaxis. And a lot of times it can be pretty difficult to recognize because patients can say, I've been eating peanut butter my entire life. Like, it's definitely not the peanut butter that caused this. It could be, right? They could develop develop an allergic reaction to it. So when should we think anaphylaxis? So we want to say an acute onset of symptoms following a suspected exposure. So the patient has to have an exposure to something that could cause anaphylaxis. So typically there's like kind of 3 different qualifications I think of. So the patient can have symptoms in 2 or more body systems. So they can have skin, they can have hives, skin itching, they can have respiratory problems like bronchospasm, wheezing. They can feel like their tongue is swollen and big, like this top picture is a patient I had in the ER that ate a pizza, and this happened to her. They could have just like throat swelling. The bottom picture, it's probably a little hard to see, but his uvula is swollen. That's uvular angioedema. They can have GI symptoms, so vomiting, diarrhea, or circulatory like hypotension. But a patient can also just have hypotension. So if their pressure is 40 over nothing and they just ate peanut butter, assume it's probably anaphylaxis until you prove it's not. Or if they have airway involvement, respiratory compromise. So if they come in and they say, my tongue is swollen, but I don't have any other symptoms, and they have an exposure to something, I'm gonna assume it's anaphylaxis until I say it's not. Okay. They may not have symptoms in 2 or more body systems, but if it's an airway problem, treat it like anaphylaxis because airways go bad really fast and there's not a lot you can do to fix it, right? All right, so how does anaphylaxis work or happen? So patients get exposed to some sort of antigen or an allergen. Their B cells make antibodies that are IgE, and those antibodies bind to mast cells. And then when they are exposed to the same allergen or antigen again, that antigen will bind to those antibodies and make that mast cell degranulate or release its contents. And the biggest content that it's releasing is histamine, which is why we treat anaphylaxis or allergic reactions with antihistamines. So the histamine's released and it binds to H1 receptors and H2 receptors. H1 receptors cause increased venular permeability, so patients can get edema, they can get hypotensive, they get bronchial and intestinal smooth muscle contraction, so they get wheezing, they can get abdominal cramping, increased nasal mucus production, a widened pulse pressure, and increased heart rate, cardiac output, and flushing. And then the H2 mediated actions are predominantly, I'd say, increased gastric acid secretion, which is why we use like Zantac or Pepcid to treat allergic reactions. Because we were block Benadryl for H1, Pepcid or Zantac for H2. So how are we going to treat anaphylaxis? So going back to the case, this super sick 2-year-old, we already kind of said it. We're going to treat her with epi, right? Epi. So dosing is for an adult be 0.3 mg up to 0.3. And if you don't know about PDStat, it's an app, costs about $5 that helps with pediatric dosing. You put in either a weight in kilograms or pounds or the patient's age, and it helps you with dosing. So this is just a kind of printout of what PD stat looks like. If you type in epi for a 4-year-old, it can give you about how much epi you should be giving them. It can give you albuterol dosing, Benadryl dosing, steroids, Zofran, all the things. And it contains normal vital signs for kids, which is hard. So if a patient is having anaphylaxis, you give them epi and they still look like garbage, you can repeat the dose at 5 to 15-minute intervals if you need it, because in 12 to 36% of cases, patients need a second dose. And patients that have a history of anaphylaxis, they say, oh, I had anaphylaxis, ended up on an epi drip, 4 years ago from peanuts, and I was in a room with peanuts. They're more likely to need a second dose if they have a history of anaphylaxis, or if they present with diaphoresis, shortness of breath, or flushing. All right, so how does epi work? I think this is the biggest thing of you knowing why we're giving epi. So epi acts as an alpha-1 agonist, which causes increased vasoconstriction, because remember that all those histamine is causing that venular permeability. So we're going to constrict those vessels. It's going to increase their pulmonary vascular resistance and decrease mucosal edema. It's also a beta-1 agonist to increase the heart rate and the chronotropy, so how much we're contracting. And it's a beta-2 agonist, so it's going to increase bronchodilation and decrease the release of mediators from mast cells. So it's going to try to prevent any mast cells that have not released their contents from releasing them. All right, so epi is great. It does all the things to fix all of our problems. So then we have adjunctive agents like H1 blockers like Benadryl that we can use, H2 blockers like Pepcid or Zantac, bronchodilators like albuterol, steroids, but really none of these medications are life-saving in anaphylaxis. They're just adjunctive agents. They're just helpful for symptom improvement or management, but they're not actually fixing the underlying issue, which is the big point I want to make. Epi is the only thing that's actually going to fix their problem. We can make them feel a little bit better. That's not fixing their problem. And this is kind of a review of that. So epi is the only drug with good evidence showing that it treats the life-threatening complications of anaphylaxis. There's really no data that supports the use of antihistamines, but they do help improve like itching or hives. Because epi, and the reason this is the case is because epi treats those downstream effects. After histamine binds to its receptors, epi is fixing the problem after histamine's bound. An antihistamine, like a H1 blocker like Benadryl, can only work if histamine is not already bound to that receptor, right? So you're only really helping those receptors that don't already have histamine bound. So that's why Benadryl and Zantac don't actually treat the underlying problem. Any questions about that? I feel like that's probably different than what most people have learned. The big point that I wanted to make. All right, so this is our patient, 2-year-old having anaphylaxis. She's 15 kilos, so we said 0.015 or 0.01 mg per kg, so she would be 0.15 IM. And then we could say give her Benadryl, Pepcid, Zantac, whatever else you want to give her, but give her the epi first. So she starts getting better. Her wheezing has improved. Her vital signs look better. Should you transport her? Absolutely, right? Yes, so we want to transport her. And the reason being is that this patient's never had anaphylaxis before, right? So she needs education on anaphylaxis. Mom needs education. Dad needs education. They need an EpiPen prescription, so they need something to go home with. And biphasic reactions can occur, which is when patients develop recurrence of symptoms an hour to 48 hours after that initial episode with really no new exposure to the agent. So definitely transport these patients. Even if it's a patient that's like, I've had anaphylaxis to peanut butter before, I had a cookie and didn't realize it, they may say they may not have another EpiPen. Maybe they use their only EpiPen and now they're calling you. I would still transport that patient because we need to watch them and we need to make sure they have a new prescription. All right, so what if the patient is showing continued signs of anaphylaxis? So say she initially gets better, then she gets worse again. What do we want to do? Second dose. And then so say you've given her 3 doses now and she still looks like garbage. What are we going to do? Yeah, make sure there's no allergen on her for sure. And then the other thing I would say is probably start going to IV epi. In the hospital setting, we would probably do an epi infusion. In the protocols, you can contact online med control for certain epi dosing, but you also can use push dose epi if you need to, right? Or microdose epi. This is in your protocols. All right, any questions about that? Yeah.
Are you trying to get it back up to that, or are you just trying to get it to the lowest, which for her would be 72?
I would just probably get it to the lowest that's normal and making her looking better. Make sure her wheezing has improved would be my biggest thing. So I would probably, I'd say like give 3 doses of epi, of IM epi. If she, still looking like garbage, start fluids at the same time while you're waiting to redose. And if she still looks like garbage, I would start going to microdose epi.
Yeah, Benadryl very much.
Yeah, and you can give Ventril, but just give the epi first. Yeah, because that'll probably help the itching.
Hey, Dr. Brown.
Yeah.
You may have mentioned it already, but is there a role for fluid bolus, and how important is that for anaphylaxis?
There is a role for fluid bolus. That is because you want to fill the tank, right? Because basically in anaphylaxis, most of the fluid that's in their veins or their vasculature is kind of going into their skin, into the soft tissue. And so we're vasoconstricting with epi, but we want to fill the tank up so that we actually have something to push back to the heart in order for the heart to push back out. All right. Next case. So this is a real patient I had in the ER. This is a 72-year-old complaining of difficulty breathing. She says she was at a funeral for her nephew, and then she just got really short of breath. She has high blood pressure, diabetes. She takes antihypertensives and metformin, no known drug allergies, but she's hypertensive to 220 over 140. She's tachycardic to 124. She's tachypnic to 32. Her stat is 84% on room air. She's in severe respiratory distress. You listen to her, you can hear like audible crackles. She sounds like she's got popcorn in her lungs, but she doesn't have any lower extremity edema. So what do you want to do with her? Or what do you think's going on?
Yeah, we do nitro CPAP for this patient. We give nitro off the rib if she's, can talk to us and all the protocols line up for CPAP. We definitely want to try to do that, try to get all that stuff out of them.
Yes, exactly. So I thought that was on the next slide, but it's in a couple slides. But yeah, so she probably has pulmonary edema. So we're going to do CPAP and nitro, which I'll talk about in a couple slides. But what the heck is flash pulmonary edema? So flash pulmonary edema, and this lady who was totally fine when she went to this funeral, has no lower extremity edema, so probably doesn't have decompensated heart failure. She got flash pulmonary edema, so she probably got really upset at the funeral. Her blood pressure got really high, and then her heart couldn't handle it, and all that fluid got backed up into her lungs. So flash pulmonary edema is an intense form of cardiogenic alveolar pulmonary edema, and the causes behind it, the triggers, the management are very similar to when patients have decompensated heart failure, but really we want to make sure we're trying to treat them a little quicker, right? Because these patients are sick. So I know this is a lot of words, but what is cardiogenic pulmonary edema? So pulmonary edema caused by the heart. So it's characterized by increased transudation of protein pore fluid into the pulmonary interstitial and alveolar spaces. So basically fluid comes out, transudation means fluid is coming out of the blood vessels through breaks or pores in the cell membrane and going into the pulmonary, say soft tissues, basically the interstitium and the alveolar spaces. So then they get edema in their lungs. The most common cause is due to a rapid increase in left atrium filling pressure, which is most commonly due to an elevated LV or left ventricle filling pressure. The majority of the time, this is because the patient has either systolic dysfunction or diastolic dysfunction. Systolic dysfunction would be caused by impaired LV contractility, so the heart is not pumping well, and that causes a reduced cardiac output, which means there's increased blood backing up to the left atrium, increased blood backing up into the lungs. That makes sense. This can be due to heart disease and acute MI, valvular heart disease, high blood pressure, and a lot of other things. And then diastolic dysfunction is basically when the heart gets very stiff, the left ventricle gets really stiff and it can't totally relax. And so it can't totally fill. And so again, fluid backs up into the left atrium, backs up into the pulmonary system. And this can be due to high blood pressure, acute MI, or an acute hypertensive crisis. So this lady probably has flash pulmonary edema because her blood pressure is so high, right? She was like 220 over 140. So her cause is most likely an hypertensive emergency or crisis. So sometimes in these patients, they can have preserved ejection fraction. So sometimes they don't have any heart failure history. My lady had no heart failure history. She'd actually had an echo a couple months ago and it was normal. So it's not because her heart wasn't pumping well. It's because she just got very hypertensive. And so she had that excess afterload, that really high blood pressure, really didn't have a lot of increased preload, but that can help cause this. But then that precipitated that development of the pulmonary edema. All right, so we already said this. We're going to treat her with CPAP and nitro. We've already talked about how nitro works, so we're going to talk about CPAP now. And I love CPAP. So CPAP is a type of non-invasive ventilation. So basically, you're delivering positive pressure through a non-invasive interface, so through a face mask. Patients can have like nasal plugs at home, but it's just not through a tube that goes into their mouth. And it provides ventilatory support for acute and chronic respiratory failure. It's most commonly used in COPD exacerbations or acute decompensated heart failure with pulmonary edema. There's a lot of benefits that have been shown through research that CPAP or BiPAP reduces the need for intubation, ICU admissions, reduces the length of hospital stay, and increases mortality. So a lot of times when you bring a patient into the hospital on CPAP, we leave them on it for a while. We try to figure out what's going on. We try to make them better, get them off the CPAP so then we can admit them to the floor, okay, to try to keep them at ICU. So that's one huge benefit of CPAP or BiPAP. Sometimes it doesn't work, but sometimes it does. All right, so what is CPAP? So CPAP is delivery of a continuous level of positive airway pressure throughout the respiratory cycle. So you get this one airway pressure the whole time, and it's going to help stent the airways open. The benefits in acute decompensated heart failure, which is ADHF, is that it reduces preload. So you have less blood flow coming back to the heart, so less blood that the heart has to pump. So less blood that's going to get backed up into the lungs because it increases intrathoracic pressure because it's positive pressure, right? It helps to prevent alveolar flaps at the end of expiration because it's helping maintain PEEP. And it decreases the LV afterload by reducing the LV transmural pressure. So basically, it's reducing afterload, it's reducing preload, and it's preventing those airways from collapsing. So CPAP is great, right? It's exactly what we want. There are some contraindications. So if a patient obviously needs to be intubated, they're in cardiac arrest, they're in respiratory arrest, CPAP is not going to help them, right? These patients need to be intubated. If a patient's really encephalopathic and not breathing spontaneously or not breathing well on their own, CPAP is probably not the best choice. They probably need to be bagged if you can't RSI them or if you can't intubate them. If a patient is actively vomiting, try to get the vomiting under control before you put them on CPAP, or don't put them on because we don't want them to vomit into the mask and then them aspirate, right? Or if they're having like hematemesis, so they're actively vomiting blood, probably not ideal to get into the lungs, right? There's a couple of other relative contraindications on here, but those were the biggest things. Or if somebody has like an airway obstruction, CPAP is probably not going to help them, right? If it's in like the larynx or if they have a tracheal mass. All right, so that differs from BiPAP. So we use BiPAP predominantly in the hospital, which is bi-level positive airway pressure. So that differs from CPAP because it delivers pressure based on whether the patient's inhaling or exhaling. So there's IPAP, which is the inspiratory positive airway pressure, which say we maybe set at 10. And then the EPAP, the expiratory positive airway pressure, that say we set at 5. So they're getting more pressure when they breathe in, less pressure when they breathe out, but they are still getting that PEEP to keep their airways open. There's a couple different modes you can use from BiPAP. You can use spontaneous, meaning the patient is initiating all breaths. It's just helping provide that pressure. You can use spontaneous or timed, which means the patient's breathing spontaneously. But so say they're like a little sleepy and they're not breathing. So say they're breathing like 10 times a minute. We really want them to be breathing like 20, 15, 20 times a minute. It can provide a backup rate just in case they're starting to fall asleep. Or timed, which is not used very often, where it's just delivery breathing cycles based on a timer that you put on. So again, the differences between CPAP and BiPAP. CPAP delivers airway at a single set level throughout the respiratory cycle versus BiPAP delivers it at different from inspiratory versus expiratory. And this is really for like patients that are on home CPAP, like use CPAP for obstructive sleep apnea, but a good review. All right, any questions about that? CPAP and BiPAP. CPAP used in the pre-hospital setting has shown good outcomes. BiPAP in the hospital setting has shown better outcomes for reduced ICU admissions. But it's a little harder to use in the pre-hospital setting. If you have a ventilator, you could do it. But just hooking it up with that in your truck, you're not gonna be able to do that. But in the hospital setting, BiPAP is better for us. Any other questions? You can ask me questions later too, if you have more. All right, this is my favorite case because I feel like it's something we don't see very often. So you have a 23-year-old that you get called out for a seizure-like activity. And you're like, what? Seizure? Whatever. You get there and she is obviously pregnant. She's 36 weeks. No medical problems, takes a prenatal, sees her OB like she's supposed to, no drug allergies. You get blood pressure 190 over 120. She's tachycardic, she's tachypnic, but she's sounding okay on room air during a seizure. And she's actively seizing. So she's having those tonic-clonic movements of the bilateral upper and lower extremities. So what do we want to do with her? MAG. Yeah, why are we going to give MAG? Yeah, so this is what? What's the diagnosis? Eclampsia, right? Yeah, so this is eclampsia. So eclampsia is a new onset generalized tonic-clonic seizure in a patient or coma in a patient that either has preeclampsia or gestational hypertension. And a lot of times it occurs in a patient that has known preeclampsia, so already diagnosed preeclampsia in the hospital, but it can also be the presenting feature. So we saw a patient recently who her presenting symptom was a seizure. Like she had not been getting a great prenatal care, had been hypertensive at home, probably in preeclampsia for weeks, and then presented with a seizure. So this happens after 20 weeks of gestation or up to 6 weeks postpartum. So postpartum patients can get eclampsia or preeclampsia. The majority of cases happen before delivery. Some cases happen when patients are in labor, and then some happen postpartum, about 20%. So this is a lot of words to tell you what preeclampsia is. But the diagnosis of preeclampsia is made by a patient having a systolic greater than 140 or a diastolic greater than 90 on at least 2 occasions, at least 4 hours apart after 20 weeks gestation. Plus they have one other criteria, whether that be protein in the urine, an elevated kidney function above, like a worsening kidney function above their baseline. But are you going to have a patient for greater than 4 hours? Not a chance, right? You hope not, right? Or you can diagnose preeclampsia with a blood pressure greater than 160 or a diastolic greater than 110 if you confirm it within minutes, right? So you can diagnose preeclampsia, actually in the pre-hospital setting, by this criteria. You still have to have other things, but if a patient has this and seizures, it's eclampsia, right? So the cause of the eclamptic seizure is really not well understood, but we think that the high blood pressure causes breakdown of the autoregulatory system of the cerebral circulation, leading to edema. So basically, the brain can't constrict or dilate well. And so it either causes edema or some ischemia, but we don't actually know. So the big treatment things that we want to do are try to prevent the mom from getting hypoxic, because if mom is hypoxic, baby is hypoxic. We want to try to terminate the seizure if you need to, if it's not already terminated. We want to try to prevent any recurrent seizures. And we want to treat the high blood pressure. And then we want to try to get this lady to a hospital that can get her delivered, right? Because the ultimate treatment is delivery.
Question.
Yeah.
So protocol there, if the patient's actively seizing, they probably not gonna have access. You can, I know that patient will take a second. And it says the patient again sees follow seizure protocol. So if you write on seeing they're seizing, then that would imply to give benzo, which I know is, kind of, if you want to get that a regular one or not, it's questionable. So now what's your recommendation on that?
I would give her an IM benzo or intranasal benzo while you're trying to get access.
First, it's contraindicated, so if you give it, you break protocol.
Yes, but in the protocols, technically you're supposed to get MAC first. But if they continue to seize, you can follow your seizure protocol. Actually have it on this slide.
Into the IM.
IM or intranasal benzo. Yeah, because honestly, that patient may be shaking so much you can't even get an IO, right? So I would try to break the seizure, so then that way maybe you don't have to get an IO, maybe you can get actual IV access,
Okay.
right? Because that's going to be better. So for the anti-seizure meds, so typically in a patient that's having eclampsia, a lot of the data shows that the seizure only lasts 2 to 3 minutes. So a lot of times you're going to arrive and they were post-ictal already. So a lot of times you don't actually have to give them an anti-seizure bed like a benzo initially. You can just go ahead and give them the MAG once you get access. But if they are actively seizing, like you said, I would probably go ahead and do an IM or a intranasal benzo to start with. Yeah.
So now we only carry Versed.
Mhm.
Of those three, is the one that's best for this patient population?
So diazepam is the worst, based on the data that I looked at for making this lecture. Lorazepam and midazolam are the better of the two options. I would give, if you're given an IM, I would give Versed. Yeah, it just works a little bit better. But yeah, the data for diazepam, is not as great. Not necessarily for poor patient outcomes, but just it doesn't work well. But so we talked about the seizure. We'll talk about MAG in a second, but we also can treat their high blood pressure. Once we control a seizure, once we give them MAG, we can also potentially treat their high blood pressure. So say you got a prolonged transport. So we're given antihypertensives in order to prevent a stroke, in order to prevent a hemorrhage, right? Because strokes happen about 15% of patients and cause death in patients with eclampsia. We're going to give it to patients that are hypertensive to greater than 160 or 110 systolic and diastolic. And the meds we would use are labetalol and hydralazine. And if you don't carry these, just when they get to the hospital, they can give them to them. Magnesium can also lower somebody's blood pressure. So potentially you're not going to get to this step, right? You're going to give MAG first. So then we talked about the seizures. So then now let's talk about MAG. So magnesium obviously is the anti-seizure medicine of choice. There's data shows that it can help prevent, it can help treat a seizure when it's actively occurring, but it also helps prevent recurrence of seizures. But typically we're given MAG to try to prevent a recurrent seizure, because a lot of times, like I said, that initial seizure is already over. We're trying to prevent any further seizures from happening. The dose is 4 to 6 milligrams. I think in our protocols it is 4. So 4 milligrams over 20 minutes, I think is the protocol. And then there's a maintenance dose that you give, which is 2 grams over an hour. And really the mechanism of how MAG works for eclampsia is not entirely sure, but we think it's because it's a vasodilator and it might protect the blood-brain barrier and try to limit that cerebral edema. But patients can get hypermag, right? They can have too much magnesium. A lot of times, if you're transporting an eclamptic patient, your transport time is, less than an hour, you're not going to see this. But magnesium, so say when the levels get above 9, they're going to start losing their deep tendon reflexes. So they're going to lose that patellar reflex, which How many times do you check up patellar reflex? Never, right? But OB is going to do this. This is what they do for eclamptic patients. They check their reflexes. If it gets greater than 12, they can have respiratory paralysis, so they can go in respiratory arrest. And if it's greater than 30, typically these patients are going to go into cardiac arrest. So there's some EKG changes you can find in hypermagnesemia. So the P wave can start getting flat. That PR interval can start getting long. The QRS starts getting wide. The QT starts getting prolonged, and the T waves start getting peaked. So those would be things to think about. Predominantly if you're doing like an interfacility transport on a patient that's eclamptic. So say she went to like a freestanding or a rural hospital that doesn't have of this. So say you're doing an interfacility transport of an intubated eclamptic patient. She initially got that a 6-gram bolus, and then they started on the 2-gram infusion. But then she had additional seizures, and you can actually treat additional seizures with more mag. It's usually 2 grams more per seizure. And when you pick her up, she looks fine, right? She's a little tachycardic, but most pregnant women are. But otherwise, she looks okay. But then you start getting alerts on your monitor, and you see this. Yeah. See, what's the treatment for hyperbag? You just causes hormone around, you're not releasing any calcium. So your calcium levels get low. So when your magnesium goes up, your calcium goes low, and these patients get code. And so the treatment would be calcium. All right, any questions about that case? That was a fun one. I just don't think we see it very often. And the likelihood of you actually seeing a hypermag patient doing like a normal, like regular pre-hospital transport patient, not an interfacility, is pretty rare, but knowing the treatment for hypermag, I think is important.
And they're preventing this in these patients with regular hypertension meds.
Mm-hmm. Well, yeah, like when they're preeclamptic already, yeah, usually hydralazine or labetalol is what they use in the hospital because it's safe in pregnancy. So in conclusion, obviously, I think what y'all do makes a huge difference, and obviously there's a lot of data that show that it does. There's a lot of data that shows that patients' outcomes are improved, especially with cardiovascular disease, respiratory distress, stroke, whenever they use EMS. And obviously continuous learning, training, listening to lectures, trying to, figure out the things you don't know can help improve patient outcomes. And this is that EKG I was telling y'all that this is a very clear STEMI that the machine didn't read as a STEMI, right? It's pretty scary, right? So like if you're not somebody who like actually knows a lot about STEMIs, you might take this to a freestanding ER, and then I'm going to be like, uh-oh, can you take this patient somewhere else? Cool. All right, any questions? Any questions from the back?
No, I think we're good. They're great cases. The preeclampsia, it's interesting that we don't really know what causes that or steps. So if a pregnant lady is trending towards showing signs of prenatal hypertension, do they put them on blood pressure medicine, or is that bad for the baby?
Yeah, no, not necessarily. High blood pressure, hypertension is bad for the baby, right? So if they have gestational hypertension, or so say they have hypertension before pregnancy, they may be on something that's not safe for baby, so they'll change it to something that is safe for baby. They can develop gestational hypertension, so they can develop high blood pressure just during pregnancy, and they can start them on something. But then after 20 weeks, if they start getting protein in the urine and those other signs, then we would say preeclampsia. And a lot of times these patients end up getting put in the hospital for preventative MAG.
Very good. So if you had like a late term pregnant lady that was having a seizure and families there and is telling you, oh, she has a history of seizures, would that change your treatment any? Would you be likely to go to the benzos earlier?
more likely probably go to benzos and then try to see like, has anyone talked to, like, when she wakes up or once she can talk to family, like, has anyone talked to her about preeclampsia? Has she ever had high blood pressure before? Because when you check her blood pressure when she's seizing, it's gonna be high, right? And when you give her a benzo, it's probably gonna be a little bit lower. But I would just make sure that the hospital knows when you transport them so they can consider eclampsia. But if they have a history of seizures, just say like, have you missed any of your meds? Are you still taking them? Are you compliant? That makes it a whole different ballgame, but I would probably be more inclined to treat them with benzos if they have a history of seizures, especially if they're not compliant. If they're compliant, then it may be eclampsia.
Very good. Thank you, Dr. Brown. It's a great lecture. We got Dr. Eversul coming up next, but first we're going to take a few minutes and let everybody stretch their legs, and we'll be back in 5 or 10 minutes. So if you're online, please stay tuned.
Is Mike on with us? Good to go? All right. All right. I have the unenviable task of trying to pack sepsis into the next hour, and I'm going to do my best to demystify this. Of all the questions I get in EMS, sepsis comes up a good bit, and I think there's a lot of confusion that surrounds this. When I was in medic school in the early 2000s, I don't think this ever even came up. Farish, I know you just went through. Did y'all discuss this at all? Very little? Okay. So I think that's part of the issue with sepsis is like, it's sort of this ill-defined thing that we really don't talk about much. So I'm going to do my best. I want you guys to stop and ask questions. We're going to work through this, and let's go ahead and get started with a case. Where'd my clicker go? Just to introduce myself, I'm Dr. Eversul. I work for the military, U.S. Air Force. I'm on a ground surgical team. It's a small 6-man team. We do like austere, forward deployed, like battlefield surgery. So we're doing this stuff kind of at the point of care, point of injury. Work at the trauma center at UAB, trauma center in Pensacola. I've been in EMS since 2003. Paramedic, fireman for a long time, went off the rails and went to medical school. So ask me questions about stuff, okay? All right, we'll get started with the case. So you and your partner, y'all are on a rescue truck, and you get dispatched to the local nursing home. 75-year-old male for decreased responsiveness, all right? You pull up on scene, nursing home staff comes out, and they walk you to the patient. And you ask him, you say, tell me about this patient. And what do they say to you? I just got here. The person who takes care of him is off on lunch. I really don't know anything about him. I think he might have cancer. And I think they said his blood pressure was low, but he ain't acting right. You go, okay. And then that person leaves and you do not see them again for the remainder of your call. So this is your patient. He is following commands appropriately. He's protecting his airway, but you can't really make out what he's saying. You're just kind of muttering and mumbling. And you don't know if that's normal for him or not, right? So you put him on the monitor. Heart rate 110, pressure 87/55, breathing 24 times a minute, sat 94% on room air, and he's got a little bit of a fever at 101. BG 108, I love it. 12 lead is normal sinus. You put him on a little oxygen, and you put an 18 gauge in and decide to bring this man to the hospital. So you transport him en route. You start a liter of fluids. You get maybe 100 of that into him. It takes 20 minutes to transport him. And then you sit on the wall at the hospital for another 40 minutes before you get assigned to a room. During this period of time, his vitals have essentially been unchanged. All right. So this is when I come in and I order labs and I order imaging on this guy, and we try to figure out what's going on with him. His labs come back and he's got a little bit of an elevated white blood cell count, and his chest X comes back and it looks like he's got kind of a hazy, opaque region in one of his lungs, and we go, that probably looks like pneumonia. And he's been here for 3 or 4 hours now, and I walk into the room to check on him, and his blood pressure is 80/40. And so that's not great. Let's say he's gotten a total of maybe 500 cc's of that fluid because he bent his arm and the IV quit flowing. Reasonable? We pressure bag some fluids in. We start him on pressors. He requires both levo and vaso to maintain a MAP of greater than 65. And this man gets to go to the ICU because of that reason. So he goes to the ICU, where over the next 48 hours, he subsequently requires increasing doses of his vasopressors to maintain that MAP of 65. His breathing gets worse and he requires intubation, and he subsequently dies 2 days later. His cause of death is sepsis. All right. Now, I know it's depressing that we've killed our first patient of the day. I think we're going to learn from this guy. I think we're going to get better and hopefully use some of the lessons in this case to demystify what we can do to change the outcome in the future. Sound good? This is my reminder. It's kind of crazy to me because in medical school, we talk a lot. You talk a lot about trauma. You talk a lot about heart attacks and things like that. 1 in every 3 people that dies in the hospital dies from sepsis. So we spend more money on this than almost anything else when we talk about like our healthcare dollars. This is a very expensive, very prevalent disease. We don't see the end result of it in the pre-hospital setting, which I think is the reason we don't focus on it as much. We normally catch this in the middle or the beginning, not necessarily as much in the end unless you have someone you think is maybe in septic shock, okay? But I just want to call attention to how prevalent this is in the hospital. I mean, that's a lot of people. 1 in every 3, same thing, sepsis, right? So, questions so far? Perfect. All right, here's our objectives for the day. Let's define sepsis and actually talk about what that is. We're going to do our best to talk about how to identify it. We'll discuss the spectrum like all things in medicine. You'll hear me say this over and over again. All things in medicine pretty much exist along a spectrum from bad to worse. You know, tachycardia exists along a spectrum from 101 to 240-ish plus, right? So, and then we'll talk about how to manage it, what I do in the hospital and what you guys can do in the field, okay? All right. One of the reasons sepsis is difficult is because we have literally changed the definition for sepsis 3 times in the last 30 years, all right? The definition for sepsis was different in the early 2000s, and it was different in the 1990s. So this is a simplified version of the definition that we're using now. I would not be surprised if this definition changes again, okay? One of the reasons that this has changed is because we've learned more about the pathophysiology of what drives and causes sepsis, and we kind of tweaked the definition to better reflect what we know and accurately depict kind of what's happening. So for now, let's call it life-threatening organ dysfunction due to the body's response to an infection, okay? Infection can be any kind of infection. It can be a bacteria, which is kind of the most prevalent thing and the one that we're, of course, going to treat with antibiotics. But you can also be septic from viral sources, from parasitic sources, from fungal sources, okay? So the term infection is meant to be kind of broad in this sense, in this definition, okay? So according to this definition, in order to be septic, 2 things have to be there. You have to have some source of infection, and you have to have organ dysfunction, specifically life-threatening organ dysfunction, okay? Does that make sense? Let's talk about the organ dysfunction part of this. One of the difficult things about sepsis is going, how do we identify which patients are septic and which patients have sepsis? And the way that we identify those patients is by looking at that organ function and saying, is this working the way it's supposed to or not, okay? In order to talk about where we are now, we need to talk about how we got here. So we'll do a quick history lesson, okay? Sepsis has obviously been a problem for forever, right? It's just the way your body inappropriately responds to an infection, okay? In the 1990s, there was a panel, a little commission that was formed, and they said, listen, sepsis is a big problem. We're losing a lot of people. A lot of people are dying from sepsis. It's a very expensive thing. We're spending a lot of healthcare dollars on it. Let's look at it, let's study it, and let's see if we can find ways that we can improve mortality, spend less money on it. And in a nutshell, spoiler alert, the way that we can improve mortality is early intervention, is to get these people earlier, right, and take care of them earlier. So what this panel did in the 1990s was they said, we're going to come up with a tool, a decision-making tool, to try and decide which patients are at increased risk for sepsis, okay? Because it's not a clear patient presentation. It's not like a heart attack like we talked about with Robson's sign and they're clutching their chest and they're diaphoretic. Septic patients, unless you're actively thinking about this, no one is going to tell you, I'm septic, okay? So the first time this group met, what they did was they looked at a lot of data and they came up with a tool and they called it SIRS for short. It's the Systemic Inflammatory Response Syndrome. And they came up with the SIRS criteria. And they said, listen, we've looked at data, and we've come up with this tool that you guys can use to identify which patients are at increased risk of dying from sepsis, okay? So if you look at the SIRS criteria, there are 4 metrics in this. You've got temperature, heart rate, respirations, and a white blood cell count. And we can look at this and we go, hey man, this is actually pretty great because we can get 3 or 4 of these out in the field, you know? That's pretty good. And the way SIRS works is if you have 2 or more of these things, then you are said to be SIRS positive, okay? And SIRS doesn't stratify how septic you are, how sick you are. It just says, are you at increased risk? In other words, you either have a temperature between 38 and 36 or you don't, you know? You either have a heart rate above 90 or below 90. If I have a heart rate of 91, that doesn't necessarily tell me the same thing as a person who has a heart rate of 170. Does that make sense? So there's no stratification there. It's either you do have this or you do not have this. Make sense? Okay. If you'll notice, sirs, if I run from here down the stairs into the engine bay and then run back up, my heart rate is going to be greater than 90 and my respirations are going to be greater than 20. That does not mean I'm septic, okay? That does mean that I'm SIRS positive. So the caveat to this and the caveat to all of these tools that we have developed is that you have to think that they are that way because of an infection. All right, I want to say that again because that's a huge, huge important point to all of this and all of these tools. In order to apply these tools, you have to also think that they are that way because of an infection, okay? Questions about that? So if you have a patient and their heart rate is 97 and their respirations are 22 and they have a fever of 101, you go, and I go, oh, I've got a cough. Okay, like maybe they have pneumonia, you know? That would change them from SIRS positive to sepsis. Does that make sense? Perfect. Not the perfect definition, okay? This group met again in the early 2000s. Group met again, and they said, hey, listen, we've got some limitations with the SIRS criteria. You know, we're getting a lot of people who are positive, but a lot of these are false positives, and we need to try and be more specific. But they didn't have a better solution at the time, so they left it as it is, and then they tweaked the definition for sepsis again, and they said, let's reconvene later. All right, so we continued to use the SIRS criteria. The group met for the 3rd time in the late 20-teens, and they said, all right, been using SIRS, and now we think we got something a little bit better. We're going to use SOFA. It's the Sequential Organ Function Assessment Score. You don't need to memorize the names of those things, okay? But they said this is a tool that is going to be better at identifying these patients. We'll have less false positives, but mother of God, look at all the metrics on this thing, right? So SOFA, we have got 6 different inputs basically for this tool here. If we look at the first one up here, we're looking at respirations again. Remember, respirations were also part of the SIRS criteria. But this time we're not looking at a respiratory rate. We're looking at the difference of the arterial oxygen versus the inspired oxygen, okay? Can we get that in the field? No. I have to put in an arterial line in the ER to get this, okay? Which means I have to take a needle, and instead of putting it in a vein, I got to put it in an artery, all right? So now I've got blood squirting out the back of it, and I take a wire and run the wire through there into the artery, and then I take a big, long IV-looking catheter and slide it over that, and then we hook a little device to it, and now we've got an arterial line, okay? Generally, we don't put holes in people's arteries unless we have to, okay? My point is that someone has to be pretty critically ill coming in the door of the ER for me to consider even giving them an arterial line. Does that make sense? So as a screening tool, I can't really even use this in the emergency room, at least this part of it, okay? Because that's not something, if you come to me and say, hey, I was just in this car wreck and, you know, your heart rate's 101 and your respiration's a little high, you know, I'm not going to go, yep, let's go ahead and get an art line on this person, you know. That would be pretty aggressive. That'd probably be malpractice at some point. So they have to be pretty critically ill to even get this first metric here, okay? We look at the rest of these. I'm looking at different metrics for organ function. I look at platelets, I look at liver function, and I look at kidney function. Those are all lab values, okay? I can get those lab values, no big deal in the ER, but you can't in the pre-hospital setting, not yet, at least, okay? So what you can do is you can evaluate their cardiovascular status and their GCS. Man, GCS is like bread and butter. We got that all day, you know? And then their cardiovascular status, we're looking at their MAPs. And interesting to me that they use this MAP goal of 70 and not 65, because most other things that we do from the ER setting, we really try and hit that MAP goal of 65. That's sort of the cutoff for things like now they need vasopressors. But for whatever reason for this, they chose 70. And this is along a spectrum. So as opposed to the SIRS criteria where you either do or do not have this stratifies how sick you are, okay? So if you score 2 or greater on this SOFA score, and you think it's from an infection, sepsis, okay? If you score a 2 on the SOFA score, you've got a 10% chance of mortality. That's no joke, all right? If you score an 11 on this, that is a 100% chance of mortality. The chances are you are not going to survive your hospital stay, okay? Most of these labs get obtained in the ICU setting, and I would argue that patients already have to be pretty critically ill to go to the ICU, right? We don't send normal healthy patients there. So SOFA is one of those things that it does a great job of predicting who's going to die in the hospital, but I would be willing to argue that if you were in the ICU, you are already at an increased risk of dying in the hospital. Does that make sense? Cool. Not super applicable in the pre-hospital setting. Again, you can get these 2 metrics, right? And you can make informed decisions kind of based on those things. I didn't add these because I don't want to add to any confusion. I wanted to give sort of a linear timeline of how we got to where we are and what we're about to talk about. There are other tools out there. For the ER nurses that are listening online, they've probably heard of news scores and Apache scores and lose scores, and there are all kinds of different tools that we use to try and go, I wonder who has this and who should we treat, okay? I don't want to get into that today because that makes it confusing. So, questions about this? Wes, anything from the internet?
Yeah, the only thing is that there's a little confusion talking about SIRS related to sepsis now, because we're still in initial education talk about SIRS, but it's always in reference to trauma patients and progression of hemorrhagic shock that results in SIRS. So has any understanding of that changed as a complication to major multi-system trauma? We talk about SIRS being prevalent in that patient population.
there are some metrics. SIRS by itself is not as useful for just trauma. But there are some metrics, the ratio of systolic blood pressure to heart rate, a cardiac shock index, and things like that that have been studied and applied to sepsis. But I think that's kind of the only overlap that I know of between what we look for in trauma and
Yeah, I think SIRS in the trauma world is more about happening after the event, not in the pre-hospital setting, but in
yeah.
the trauma burn ICU, identifying patients developing SIRS after the multi-system trauma.
Certainly in our burn patients specifically, our burn patients, their risk of developing an infection is through the roof. And so certainly if I had a burn patient that I admitted to the ICU, I would imagine they would want to track a lot of these metrics, for a significant burn. Because again, it gives me another opportunity to emphasize that the treatment for this is going to be early intervention, is to get ahead of this. So, good question. What else?
That's all I got for now.
Perfect. All right. All right. Hopefully this wasn't too bad. Okay. I know there's a lot of metrics and a lot of labs and a lot of numbers up here. I submit to you guys that let's use this in the pre-hospital setting. If you've got to pick a tool to use, let's use this one. Okay. This is the quick SOFA score. So it's a modified version of the SOFA score, the one that had the 6 different metrics and all the labs. It's simple to use. It has 3 inputs, and we can get all of them in the field, so we can actually, look at everything we would need. So altered mental status. Do they have a GCS of less than 15? It looks at respiratory rate. Are they breathing greater than or equal to 22 times a minute? And it looks at their systolic blood pressure, not their MAP, but their systolic blood pressure. If that's less than 100, they get a point for each of these, okay? If they have 2 or 3, then they wind up with a 3 to 14-fold increase in in-hospital mortality. So if you're in the field and you're wondering, should I give antibiotics to someone? This would be kind of the easiest, most applicable tool that you can use, okay? This is not the only tool, right? Notice that this doesn't have temperature. In some of the metrics are a little different. If you want to use the SIRS criteria, even though you can't get a white blood cell count, you can use your clinical judgment and say, the person's got a fever of 103, their urine smells nasty, they've got a heart rate of 110. Like, that's fine. Yeah, heart rate's not a part of this, temperature's not a part of this. This is just a tool, okay? I think we should all have at least a tool to use for this. If you want to have more than one and piece together bits of SIRS or SOFA, that's fine, so be it. Have those pictures on your phone and do that. But I think if you got to pick one, this is the one, okay? It's easy to do. I will say that I anticipate this is going to change, I anticipate that over the course of your careers in EMS, that this is going to change. That and things generally change for the better as we learn more about them. So I suspect that we will get more applicable tools specifically for like the pre-hospital setting. But one of the other things to think about, right, is when we're talking about sepsis, we're trying to identify organ dysfunction. This is something that will probably change in the 10 to 20 year timeline horizon in terms of being able to assess organ function with labs, with actual blood work in the pre-hospital setting. iStats already exist. That's not a big deal. I mean, they use those all the time in the hospital. When I'm downrange, we have iStats that, that's our entire lab. So you can get some of these numbers, but I think that as that technology becomes smaller and more affordable, it's going to trickle down to EMS, and this is going to be where we apply those things, okay? If I'm also thinking on that like 10 to 20 year horizon, this is a huge opportunity for AI and machine learning, is this right here, is because what you're doing is you're taking a sort of nebulous opaque problem, and it's got multiple inputs. We just looked at like 3 different tools that we could use to say, does this person have a problem? AI is really good at that. AI is really good at sifting through a lot of data and trying to give you a suggestion. I'm not saying they're always going to be right, you know, but I think that that will help speed this process up, you know. So honestly, look for that on the 10 to 20 year horizon as well, as stuff like that trickles down. So questions about identification of sepsis in the pre-hospital setting. Everybody get a chance to get a picture of this? What you got? Definitely. Definitely.
Still give her a separate drip. I can still give like an antibiotic and maybe some fluids in the pre-hospital setting, getting them to the hospital.
Yeah.
That's pretty much what we would.
Yeah. 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 I mean, it's
This.
correct. Right. Exactly. Exactly. Um, and to that point, right, sepsis, you can be septic from a number of different sources, right? Um, if we go back to that definition, you know, it just says from an infection, not necessarily in fact, it's a really good point. One of the recent questions I got about this, and someone said, well, I thought sepsis was an infection in your blood. Well, sepsis can be an infection in your blood. That's bacteremia. So you can have an infection of the bloodstream that causes sepsis, but you can also have a pneumonia that causes sepsis, or a urinary tract infection that causes sepsis, or a big sacral decubitus ulcer on these bedbound patients that cause sepsis, or an encephalitis. It doesn't, anywhere you can get an infection that can cause sepsis. And so that's kind of the hard part, is you really have to be clinically savvy to keep it on your differential. If you're not thinking about it, you'll miss it, you know. So good question. All right. We ready to move on to talk about the spectrum of sepsis here? Everybody good? All right. All right. Again, most things in medicine exist along a spectrum of disease. So this is when we'll talk about the rough, the very rough pathophysiology for why this happens. So sepsis doesn't start as septic shock, right? Sepsis starts as a local infection somewhere. And then there's this out of control response from the body to that infection that results in sepsis, okay? So the normal host response, normally, if you encounter a pathogen, your body will trigger this inflammatory response to help fight that pathogen off. Once that pathogen is contained or eliminated, things go back to normal, and that's homeostasis, okay? Let's take this guy, for example. This is a guy that I took care of in one of the military settings. So if you can, does this have a laser on it, Wes? Oh, it does have a laser. It ain't gonna work. All right. Everybody can appreciate this area here. Everybody see that? It's red. Can everybody appreciate that it's a little bit swollen? Perfect. Can everybody appreciate that it is contained to this area, that I could draw a circle around this? Perfect. All right. This guy has a cellulitis. There's a little infection in the skin right there. And right now, it is localized and contained, and this man is otherwise well appearing with normal vitals, okay? He encountered a pathogen that invaded the cutaneous layer of the skin right here. That resulted in an immune response. And there's a tricky slide in just a second here. So that immune response resulted in some vessel edema, which is why you see that swelling. It results in vasodilation, which is why it turns red. And it involves the recruitment of immune cells, which move to this site to help fight that infection off. And that is the inflammatory response, okay? Those things in a nutshell. Those things then contain this pathogen, and you wind up with resolution. In other words, that swollen red spot goes away and his arm looks normal again. Does that make sense? That is the normal response to infection, okay? This is the tricky slide. There's a lot going on here. I don't expect you to memorize any of this. I wanted to put this in here just as an illustration. What I just described here was just very broad. Here's what happens, okay? There are a lot of things that happen on a cellular level, on a micro level, okay? This is why sepsis is so tricky and why we're still learning a whole lot about it, all right? Have y'all ever heard of cytokines or interleukins? I had never heard of these till I was in medical school. I had no idea, you know? Certainly was not taught to me as a medic, and certainly never came into play in my daily kind of job on an ambulance or a rescue truck. So I just wanted to point out that up at the top here, you've got a few different kinds of white blood cells because there's a bunch of different kinds of white blood cells. When those white blood cells encounter a pathogen, they send out signals that tell other cells to come and help and tell the blood vessels to do things, all right? That signaling pathway, those little proteins that it puts out are cytokines and interleukins, and those go into the bloodstream and they circulate all over the body, all right? And that's how you get this localized response. Those messengers are responsible for telling the blood vessels to open up and dilate, and they're responsible for telling the cell walls that hold the blood vessels together to open up a little bit so that the white blood cells can get out of the bloodstream and into the tissue to fight infection. That's where you get the swelling and the edema, right? There's a lot happening here, okay? Sepsis is when this process goes haywire and it becomes not localized anymore, and all of a sudden you have a systemic response across the entire body, okay? Does that make sense? I know this is a confusing slide. There's a lot here, okay? All right. The abnormal host response is what leads to sepsis. So my man has got this infection on his arm. Instead of this localized response, let's say that this is a much simpler version of that picture. So let's say that he's got a macrophage. It's kind of white blood cell. A macrophage comes into contact with this bacteria in his arm, okay? And the macrophage says, man, this isn't supposed to be here. I got to get some help. I got to get this out of here. This is the equivalent of being in like a fire truck and driving down the street. You're the macrophage. The fire truck is the macrophage. You're driving down the street and you see a building on fire. Well, you don't do it by yourself. You get on the radio and go, hey, I need a battalion chief and a rescue truck and 3 more engines and a ladder truck and the power company and the gas company. And I need the police over here to block off some stuff. There's a lot of people involved, you know. So the macrophage basically sends out that initial signal and goes, hey, I got to get help over here. And that triggers this downstream cascade of events, just like it would if you were to drive past a building on fire, okay? These specific interleukins, these little proteins, they circulate through the bloodstream. And when they reach the hypothalamus in the brain, they bind to receptors that result in fever, tachycardia, and increased respirations, okay? I want to pause there for just a moment and rewind back to our SIRS criteria. Do you remember what the 4 criteria for SIRS? We looked at white blood cell count, fever, tachycardia, and respirations. So it's not hard to see how they arrived at that conclusion based on just the physiology of how this works, right? Does that make sense? So it makes sense, right? You go, oh, well, these are the things that happen when you get an infection. We should screen for this, okay? But these do more than just act on the hypothalamus. They act all over the body. They act on the blood cells, on the capillaries, and the arterioles. It leads to changes in the way that we clot. and it tells the blood vessels to vasodilate and open up. So we get that redness and that edema. The problem is that when this is not local and you tell all of the blood vessels to open up, what happens? Vasodilation everywhere, right? Results in, yeah, exactly. Hypotension, shock, exactly. And shock is when the tissues can't perfuse themselves. So all of a sudden you've opened up the blood vessels. Not only have you opened them up and made them bigger, you've made them leaky so that you can push stuff out of the blood vessels and into the tissue, okay? When we resuscitate for sepsis, this is why we resuscitate with fluids, because they need the volume, all right? This is going to result in a decreased ability to carry oxygen through the bloodstream and bring that oxygen to the organs that need it, okay? And by definition, now we're in like shock territory. So now you have organ hypoperfusion. They can't do anaerobic metabolism and they have to switch to anaerobic metabolism. This is like when you sprint and your legs burn, you get that increase in that buildup of lactic acid. So now you're getting a buildup of lactic acid, okay? Eventually, this leads to organ failure and death. This is how you die from sepsis. Does that make sense? It doesn't matter what the bug is. It doesn't matter if it's a virus. It doesn't matter if it's a worm. The pathway to death is the same, okay? Does that make sense? Okay. All right. So on that spectrum, as that immune response kind of leaches away from that localized area and becomes systemic, you start to move down this spectrum to shock, which ultimately leads to organ hypoperfusion and death. Exactly. All right. Questions about that? We know that for sure the longer you wait to intervene, the higher the risk of mortality is. And those studies have been done. I've actually got a slide here and a couple that basically, basically says for each hour that you wait to resuscitate and give antibiotics, their chance of mortality goes up by like 11% every hour. It's different for different people. I think younger, healthier people who are more physiologically resilient are going to be able to hold out longer. You know, the 90-year-old that has diabetes and vascular disease and, host of other problems is not going to have the same physiologic reserve. And it's probably going to, succumb sooner. Yeah, correct. Yeah, kids do a really good job of compensating until they don't, absolutely. Well, and that's the battle. That's where all the research money goes. And just to be clear, this isn't hemorrhagic. This is distributive, right? You've opened everything up, and that actually brings up a and I think the next question is, well, why don't we give them blood and put that back in? And we've actually tried that. There have been several studies that have looked at that, and we get these patients in septic shock and resuscitate them with blood. And it turns out they don't do great. So I don't want to get too into the weeds and too complicated, but as it turns out, the working theory, and it's just a theory right now. What the working theory is that this pathway, this situation actually interferes with the way that the cells are able to uptake oxygen and utilize that oxygen, not necessarily getting the oxygen to them. Okay, so there's a problem that exists at the cellular level to some degree that prevents, even when we get them oxygen, the utilization of that oxygen in the cell. So I wasn't planning on getting into all that. That's bonus material. So, but yes, that's that's where all the money in sepsis is right now, is how do we know what the tipping point is? Because if we knew that and we knew that early enough and we said, if they cross this threshold, this is what we need to do, then that would kind of be the gold standard. There's still some debate on what that is. And that's why we have the SOFA, the SOFA score right now is sort of the gold standard, but only in the intensive care setting, So we have the QSOFA, which can be our gold standard for right now until we can do something or come up with some metric that we can all agree that if we cross this line, this is a problem, this is sepsis, we have to treat it, So it's some degree, because everything exists on that spectrum, we just have to agree where the threshold is. Good question. Yep. What else? Wes, got anything from the internet before I move on? All right. All right. This is straight out of the protocol book. So this is kind of where the rubber meets the road. What do you guys do out in the field for this? The sepsis protocol was new for the 10th edition. This has only been around for a couple of years now. The sepsis protocol does not tell you who is septic. It just says, if you have someone you think is septic, do this, right? This is why we spent a lot of time, why I wanted to spend time on QSOFA, to give you guys a tool to say, all right, QSOFA starts at the top of this sepsis protocol, and if they have 2 or 3 of these, boom, I can do the next thing. All right? Good? So the big things that we're going to do for sepsis is we've got to resuscitate that intravascular space. This is why we give the fluid. It's because of that vasodilation. So we got to get the fluid to try and clear that lactic acid and get everything perfusing. There are 2 groups of people, spoiler alert, they're on the board, that you don't want to give a giant bolus of fluid to, right? Heart failure patients and renal failure patients. If you give a heart failure patient too much fluid, you'll drown them. The fluid will leak into their lungs and their heart won't be able to beat, and you'll make them worse than they were when they started. Heart failure patients can be tricky to treat regardless of why they have called 911. It could certainly be difficult to treat in this situation. This is like to your point, these people don't have the physiologic reserve, to do well with this. But they are certainly not someone that I would dump 2 liters of fluid into right off the bat, because you're going to be in a world of hurt. And to Julie's point, they'll be on CPAP, and you'll be trying to push the fluid out of their lungs. And then our renal failure patients, right? They can't pee. If you give them all that fluid, it stays in them until they go on dialysis. And you can very easily volume overload them too and make them worse. So those are the 2 groups that I would say, it's not necessarily they don't need any fluid, but I would not start out with a 20 milliliter per kilogram bolus of fluid in these patients, okay? I always plug ultrasound when I do these things. Ultrasound is a tool, gives you a tool to actually objectively say they do or do not have increased volume. If you can look at their IVC, which is a pretty quick, easy thing to do with the ultrasound, put it right here. You can look at their IVC, and if it's gigantic and blown up, it tells you they have a lot of fluid, and they probably don't need any more. If it's flat and it occasionally gets a little big and they breathe and it flattens back down, they can handle a little bit of fluid, okay? We can talk more about it in the future with more ultrasound stuff, okay? But there are tools out there that are in the pipeline that are going to become standard of care that you can use to help determine this.
Here.
Sure. Yeah, great question. So the question is, are there any drawbacks or negative side effects of giving antibiotics for someone who is septic, maybe from a non-bacterial source, so someone who has a virus? So certainly if I have COVID, right, virus, my heart rate can be up, my respirations can be up, I can have a fever. And, I've worked in the hospital during COVID, so a lot of people die going to shock from COVID, it's a risk benefit thing. Okay. So the risks of giving somebody antibiotics that maybe doesn't have that infection is there's a risk of antibiotic resistance. So you give them this medicine and it's not enough to kill all the bacteria. Some of the bacteria survive and they are pretty clever at developing little ways to then be resistant to that antibiotic in the future. And that's how you get these resistant, like MRSA, this methicillin resistant staph infections, you know. So we see this all the time with like urinary tract infections, specifically in patients who have like indwelling Foley's in. They have a device that goes from the outside to the inside. It's a highway for bacteria to get in, and typically urine is a good thing for them to live on. So these are people who get lots of urinary tract infections and subsequently get lots of antibiotics. And then when we send that to the lab and they grow it out, we find out that bug is resistant to lots of different things. Okay. So there is a chance of that. And my infectious disease colleagues are, you know, probably losing their minds, but how sick is the patient, right? You know, if this patient is really sick, what is the risk of them developing an antibiotic resistance versus the risk of you not treating a potential bacterial source? You know what I'm saying? That's what you're balancing. And there's not a black and white answer for that. Okay. That's the difficult part about this, is that there's not a black and white answer. The other drawback for the antibiotics, it may give them a little diarrhea. If they're allergic to it, that obviously would be a problem. But, you know, Dr. Brown covered allergic reactions, so you can fix that problem, you know. Those are kind of the three things. So I would argue that those are all downstream effects. Those side effects outside of an anaphylactic reaction would happen on the order of days to weeks to months. If you've got a patient that will not survive days to weeks to months unless you intervene now, then you know what you got to do, you know. And we did this a lot with COVID. These patients would come into the hospital super sick and they would have COVID and their lungs would look like trash, but that doesn't also mean that they don't have a bacteria that set up shop. Generally, any hole you have, any tube that exists in the human body, if you plug up part of that tube, it sets up a great breeding ground for a bacterial infection behind it. Think about ear infections. You have eustachian tubes that connect the mouth to the inside of the ear. A lot of times you can get these viral, you know, upper respiratory infections, a rhinovirus, and it creates a lot of inflammation, okay? Those tubes are real small, one of them gets inflamed, and it sets up a great opportunity for bacteria to get behind that and become an ear infection, okay? So just because they tested positive for some virus doesn't also mean they can't have a bacterial infection. If this is an ill person that's sitting in front of you, I would argue that it's in their favor to go ahead and treat them and give the antibiotics. Does that make sense? Questions about that? All right. So fluid resuscitate and then give antibiotics. The protocol is interesting to me that you do all this and then you check a blood glucose. I think blood glucose, you know, specifically if we're using Q-SOFA, one of the metrics is a GCS. I personally would not go, oh, you know, they've got a GCS of 10, you know, and the respirations of 24 and give them fluid before I check the sugar. So take that as you will. I would check their sugar first before I decided to treat them with 2 liters of fluid instead of dextrose if that's their problem. Okay. This is going to get revised. This is not going to be forever. This is going to get revised and moved around. My hope is that Rocepin's a pretty good antibiotic, you know. We should be giving it to all of our open fractures in the field. And we should be giving it to people that don't have contraindications to it, that we think are septic. I think it'd be nice in the future if we had additional antibiotics. I think it'd be great to have broad spectrum antibiotics, but that's a whole nother battle to get fought. I'm actually glad that we have this, and I think if we do a good job of this, that the door will open and we'll be able to use more broad spectrum things, okay? Because not every antibiotic works on every bacteria. Yeah, yeah, give them some Rocephin, yeah, yeah. If you think, yeah, I mean, when I'm downrange, if you've got something penetrating, you get ertapenem, something in the abdomen. At the military hospital, we give ertapenem for appendicitis. In the civilian hospitals, we give Zosyn for appendicitis. They both work. It's just, there's a lot of antibiotics out there that cover for a lot of different things. So we've got options. Ertapenem has been used pretty extensively in the pre-hospital setting on the military side. I'm hopeful that trickles down to what we're doing here because it's got a good shelf life. The dosing is easy. I think it would be a good fit for this. So, hopefully we can get something like that in the pipeline. Yeah. Cool. Good question. That's a really good question. So cultures in the field is a really good question. So on the hospital side of things, not necessarily the pre-hospital side of things, there are metrics that determine whether the hospital gets paid for treating someone with sepsis. The bean counters at the hospital want to make sure they get paid for the patients that we're seeing. Makes sense. But they put together what they call a sepsis bundle, and it is not an easy thing. And fortunately, it's not y'all's problem. But it requires timely identification, appropriate treatment, or an explanation why you didn't, and then a reevaluation at a certain time metric. Okay. I don't know. Our numbers are usually less than 50% in most places. It's not because people are idiots. It's because it's a very difficult metric, when you're managing a lot of other patients to hit these like very specific time goals. One of those metrics is, did you get blood cultures before you started antibiotics? And so when this initially happened and we said we want to start giving antibiotics in the field, there was a small uproar from the people whose job it was to make sure that we met these metrics, who said, this is going to mess everything up. That involved a lot of phone calls and digging and looking into things. And this will not mess up any of those metrics. If you give antibiotics in the field, that's totally fine. You do not have to get pre-hospital blood to do that. They can still get their blood draws at the hospital and still meet their metrics. So if you get some backlash for that, just know that it'll all be fine. The world will not burn down. The metrics can still get met, even if you do this. If you, one of the logistical issues we ran into when this initially happened was we said, well, we'll just get blood in the field. We're going to start an IV on these people anyway. But in the hospital, they are getting blood from two separate sites. And there were a lot of concerns that were brought up. They're like, well, the ambulance is dirty. I mean, guess what? The ER is dirty, So we do see a lot of contamination, even on the ER side. It's not uncommon to see, what we call strep epidermidis, which is a bacteria that is always on the skin, grow in these tubes. And that just means that the site didn't get cleaned or dried enough. Yeah. So from a pre-hospital standpoint, it would require you to stick the patient twice. The IV stick site would be fine, but then you'd have to stick them somewhere else. Maybe not a big deal. But then you would have to get little vacutainers of blood. And what we found was that there are different vacutainers of blood to do this, and not all hospital labs accept all vacutainers, and it became a logistical nightmare. And it was just easier to go, nah, this is ridiculous.
Yeah. Oh,
So,
yeah. You're talking about like urban,
yeah,
in the austere environment. If that makes its way down to EMS, do you think we're going to have a lot more resistance? Especially to know that's pretty powerful antibiotic, right? I mean, that attacks a lot of things. And also, do you think with the protocol update, you're going to say, based on like a physical assessment of the source of infection, you're going to have to prefer antibiotics over others? Like for example, if you have a UTI, well, from what I understand, for septic isn't usually your first choice if you have options for things like that.
It'll work.
Things that are more gram positive versus gram negative.
Right.
Yeah.
UTIs are a little bit notorious because I think of all the infections, they have the greatest variability in their resistance. But I think the short answer to that question is like, yes, the more you give an antibiotic, the more you will see antibiotic resistance. Yes, absolutely. The goal is to be as specific as possible. what we do in the ER is this broad spectrum thing. We give them Vanc and Zosyn and we just nuke them. We're going to kill everything. We're killing Pseudomonas. We're killing MRSA. We're going to kill it all, because a lot of times we don't know where it's coming from or what the source is, and it usually is a few days, it's got to go to lab. If it's urine, it's got to go to lab and grow out. We might get a prelim in 24 hours. They might say, hey, it's gram-positive clusters. And you can go, okay, we can kind of narrow down based on this, but you still don't know if those gram-positive clusters are resistant to the thing you're going to give them. So yeah, I mean, if you wanted to retire on a yacht somewhere, you come up with a way to figure out quicker what these things are resistant to, you invite me on your yacht for lunch. I'd love it. But yeah, no, you're right. I mean, the more you give an antibiotic, the more you're going to see resistance. And the gold standard is to, once you identify what this thing is and what it's susceptible to stop everything else and taper to what works for it. Make sense? Questions online? All right. We're making sepsis make sense. All right. I actually discussed this a little bit earlier. This is basically just a graph, and it shows that the longer we wait to give these antibiotics, the higher their rate of mortality is. I would argue that we are in a very good position if we can identify this early to treat this early. There are transport times, there's wall times. Even if you get into a room, if it's a busy day or there's a resuscitation, like it doesn't mean that a provider goes in there immediately, sees the person, you know what I'm saying? Like there's a lot of things that we can kind of cut the red tape through and fix this problem. So in terms of the rest of this protocol, it basically says give fluids, then give antibiotics. And then if they are still hypotensive, this protocol does not quantify what they call hypotensive. MAPS. This is when I would prefer for you guys to use MAPS. MAPS of less than 65, okay? That's hypotensive. I suspect Q-SOFA will change because right now it's difficult. Q-SOFA is using a systolic blood pressure, and I'm telling you here to use a MAP, right? I think use your Q-SOFA to say this person is or is not septic and does or does not need antibiotics. But then I think your patient management needs to be based on the MAP goal, okay? Because that's how you're going to titrate your vasopressors any other time, whether it's cardiogenic shock or some other kind of distributive shock. Like that MAP goal of 65 is a very reasonable MAP goal for almost any resuscitation that you're using pressors for. Make sense? I know it's not explicitly stated here, but pencil that in. All right. And there you go. I mean, we've hit this several times now. This is the biggest point. I think take that, put it at the top of the algorithm, check your blood sugar earlier, and MAP goals of 65, and you've got a pretty efficient sepsis algorithm for the tools that we have for right now. Okay. How we doing on time, Wes? Okay. All right. I've got a few cases here that we can run through just to kind of drive home some of these points. We'll run through them pretty quick. Remember this guy at the nursing home? You're back at the nursing home. Same situation, same vitals. Check it out. This man has 3 out of 3 Q-SOFA. What do you want to do for him? Yeah. What are some clues here that make you think he has an infection? He's Q-SOFA positive, right? But you also have to suspect an infection. Yeah, he's in a nursing home. He may have ulcers. What about his vitals? What in his vitals would help kind of also point you in that direction? He's got a shock index. Yep. What else?
Story rate over 22.
Mm-hmm.
He's feverish.
He's got a fever, yeah. Yeah, so I mean, Q-SOFA doesn't have fever as part of it, but that's a pretty simple way to go. Yeah, this person's probably got an infection, got a little fever. Will it tell you if it's viral? No, but you can only play the cards you get dealt. All right, next steps in his care, like you said, Let's get this man some fluids, get this man some antibiotics. I had kind of a longer extrapolated version of this case where basically, long story short, he would have gotten antibiotics 3 hours earlier if you guys had given him on scene than he would have in the ER. And that would have been a pretty meaningful difference in his care. So, all right, case number 2. Got a 29-year-old. She's had 3 babies before. She's pregnant with her 4th. She's 34 weeks. She's not eclamptic, Dr. Brown. Dispatch says, patient thinks her water broke. Takes you 22 minutes to get there. You walk in, you got a patient on the bed. Pretend it's not a hospital bed. You got a patient on the bed. This is what she looks like. And this is on the floor. All right. And these are her vitals. Is this sepsis? Seeing some head shake. Who's going to be brave and say it? Is this sepsis or something else?
Something else.
This is something else. Yeah, this is hemorrhagic shock. This lady is bleeding out. Does she meet criteria for sepsis? By Q-SOFA, does she meet this? Is she Q-SOFA positive? Absolutely. Will she benefit from IV fluid and antibiotics? No. She needs blood and to make it stop bleeding. Okay. This is TXA and diesel fuel prayers. All right. 81-year-old dispatch for altered mental status. She's got a history of high blood pressure, diabetes, CHF, hypothyroid. Daughter says she hadn't been acting right. She's a little confused. Daughter says her urine smells. Yeah, she has a UTI. I love it. So you're already cued in, like, just based on those things, you're like, all right. I mean, she's altered. So you already know that she has 1 point for her Q-SOFA. Blood pressure looks pretty good. She's got a systolic of 115, but her heart rate 98. Respiration's 24, so she fails the respiration test. She's got 2 now. What's that?
Check a BG.
Yeah, check her blood sugar for sure. Yeah. What do you want to do with this lady? Fluids or no fluids? No fluids. How come? She has congestive heart failure. I guess it's not to say no fluids. It's to say consider not. Look to see if she's volume overloaded. That gets a lot easier when you have a tool like an ultrasound where you can objectively say yes or no. But I would be hesitant. And it looks like the rest of her vitals are pretty good. So she's not someone that I would say, she's certainly not at septic shock, So when we look at that spectrum, she's probably not on the shocky end of the spectrum. She's kind of down here somewhere. Would she benefit from antibiotics if you think there's an infection there and she's already a little altered and has positive Q-SOFA? Yeah, probably so. I would give her the antibiotics. I would hold on the fluid. Okay. How about this guy? It's our last case. How does he look? He looks yellow, right? Jaundice is from the failure of a specific organ. Which organ is not working? Liver, right? And when we talk about sepsis, we talk about organ failure. So you walk in and this guy is not acting right, and you consider the way he looks and go, man, I wonder if he's got some liver failure. You already have a patient that walking in the door has some sort of organ dysfunction. If you think this patient is septic, absolutely pull the trigger on the antibiotics and the fluids if they can take it, okay? Does that make sense? Did we just demystify some of sepsis? All right. What questions do we have?
I apologize because I was late
You're good.
here. Did you mention anything about, entitled CO2, under 25 being a indicator for sepsis?
That
It's
may be,
SOFA.
that may be in SOFA. It's not in SIR, or it may be in SIRS, not in, yeah. I don't think there's an end title measure on here. But again, the thing about developing these tools is we're all just trying to put together a way to identify this. That may be a good way to do it. I suspect someone with a higher respiratory rate would probably have a lower end title. that may be in the future, one of these metrics that we can use in the field because we can get that, you know. But there's a lot of NIH money right now out trying to figure out what the best combination of things are to identify these people. So this is going to change. This is going to change over the course of your careers. This is going to evolve and become more specific. And hopefully we'll get more antibiotics and be able to take care of it better. So it's a real problem.
Lower end-tidal CO2 would also, correct me if I'm wrong, indicate less aerobic metabolism, more anaerobic metabolism. If you could couple that with point of care lactate, you could really make determinations. But I would be careful using end-tidal CO2 alone in a perfusing patient and saying this is an indication of shock because it's far more sensitive to respiratory rate.
Yeah. And lactic is a thing we can already get with an ISTAT. I mean, I can run a VBG and get a pH and an ISTAT with a lactic level, you know, which is, well, not on this, but on the spectrum, when we decide if it is septic shock, it's a refractory lactic acidosis that you look at. So to say septic shock, you say, well, I've given them fluids and they haven't responded to them, and their lactic is persistently over 4. So not in these metrics to determine, but those are the metrics where we go, is this septic shock? Yes. What you got? Go ahead.
When it comes to the fluid resuscitation, obviously that's a huge component.
Mhm.
We carry saline and LR.
Mhm.
In your practice, which one?
Either one.
Either one.
But yeah, there really haven't been meaningful differences in those. Blood is a bad idea. You know, colloid fluids are a bad idea. Either of those will be fine. And they've purposely not specified in the past. They just say crystalloid fluids. So either one of those things is fine. Frankly, whatever you have, you know, I don't know if you guys are aware, but when the hurricane went up through North Carolina, it wiped out the plant it's the Baxter plant that makes the normal saline. So we're going to have a shortage for a while. So
I know the hospital here, South Baldwin, is very particular about how much fluid we administer prior to hospital because it's part
Yes.
of the protocol.
because that's one of the things that you have to put in the billing metric on the hospital side is we say they need to be resuscitated with this much fluid. After that happens, they need to be reevaluated. So we need to know how much fluid they've had so that we know when, you know, to reevaluate them after we give an additional amount. We don't want to give 2 liters in the field and then give another 2 liters in the hospital for sure. But yeah, we definitely, it's poor form to show up and go, I don't know how much fluid went in. Don't do that. What else?
All right, very good.
All right.
Thank you, Dr. Eversul. Great lecture to everybody. Thanks to the City Forest Fire Department for hosting us today. If you're watching online, the link to the attendance form is in the Q&A. If for some reason you can't get that, you can send an email to Alabama EMS challenge@gmail.com. You'll get an automated response with a link to the attendance form. The attendance form for today has a password, and the password is Sepsis, SEPSIS, all lowercase. If you're here with us in person, I'll put the code up here on the big screen in a minute for you to download the form, get your certificate emailed to you. Thanks, everybody. And next time that we'll be live will be from the Alabama EMS conference in Orange Beach here in just a couple of weeks. So if you hope to see you at the conference in person, but if you can't make it, please join us online. We'll see you then.